Almost a third of the cases are undiagnosed. It is the leading cause of non-traumatic amputations, blindness, and end-stage renal disease. It is also the leading cause of death due to cardiovascular disease. Hospitalization rates for people with diabetes are 2.4 times greater in adults. And what we're seeing with our diabetic patients is that prevalence is increasing. And the reason for this is that we're starting to see type 2 diabetes affect children and teens. This is referred to as maturity onset diabetes in youth. And the reason that we're seeing this is because this population has more obesity, lack of exercise, and they're not maintaining their ideal body weight. What is diabetes? It's a group of metabolic diseases characterized by increased levels of glucose in the blood, referred to as hyperglycemia. And this results from defects in insulin secretion, insulin action, or both. So when we look at our diabetic patients, it's important for us to So now we're going to take a look at the bounce and what occurs when we look at type 1 diabetics. When we look at the signs and symptoms of our type 1 patient, so when we're giving insulin, we need to look at the onset, the peak, the duration, and the nursing implications prior to giving this medication. I'm going to refer you to Brunner, page 1500, table 46-3 for this information. So when we look at our first one, the rapid-acting insulin, this is going to be used for rapid reduction of glucose levels. We use it to treat postprandial hyperglycemia. It's used in combination with longer-acting insulin. Our short-acting insulin, or our regular insulin, is going to be our clear insulin. We usually administer this 15 minutes before meals. It can be given alone or in combination with longer-acting insulin. And it is the only insulin that can be given IV. Our intermediate acting insulin, or our NPH, is our cloudy insulin. And when we look at this, we could see that our peak is about 4 to 12 hours. So this is where, when we talk about nursing implications, if we're given this medication in the morning, okay, we know that the peak is about 4 to 12 hours. So at about that 6 to 8 hour mark, we're going to expect to see that glucose level go down. So this is where we need to educate our patients on making sure that they check that glucose level at that point, and sometimes they may need a snack. And if patients take this insulin at nighttime, we worry that, in the middle of the night, their glucose level may drop. So these patients, we generally will give them a snack at bedtime to prevent that hypoglycemia with these patients. The long-acting insulins, so when we look at these, the important thing to remember is that these are continuous with no peak. The important thing to remember is that we need to give these at the same time of day. Doesn't matter what time. You can give it morning, noon, or night. It just should be given at the same time every day to keep that constant steady state for these patients. This insulin cannot be combined with any other insulin, so you cannot mix this insulin with anything. So, as nurses, we need to emphasize which meals and snacks are being covered with this insulin when we're educating our patients. We know that our short-acting insulin. It's going to increase, it's going to help for the increased glucose after meals for patients. Our intermediate glucose is going to take care of subsequent meals for patients, and our long-acting insulin is going to keep that steady state for the patients. So if we look here, this just shows you the normal. So when we give patients insulin, what we're looking to do is, the next approach I'm going to talk about is the intensive approach. The insulin pump allows the most flexibility. You can see here just how when we looked at the other, so when we look at self-monitoring of blood glucose levels, when we look at our type 2 diabetics, when we look at our signs and symptoms of our type 2 patients, you're going to notice that they're. So when we look at risk factors related to diabetes, we look at things that are modifiable and non-modifiable. So the things that are non-modifiable that we cannot change would be our family history. We know that with diabetes, we had mentioned that there may be some genetic predisposition for this. So when we're looking at our health history, we are going to ask patients, do you have a parent, a grandparent, or a sibling who has diabetes? When we look at race and ethnicity, again, something we can't change, but we know that we see it more commonly in African Americans, Hispanic, Native Americans, and Asian Americans. And again, age is something that we can't modify as well. We know that women who have gestational diabetes during pregnancy or who deliver babies over 9 pounds are also at an increase for diabetes. Things that we can change that are modifiable would be obesity. And obesity is a risk factor for diabetes. This is directly associated with insulin resistance due to the increase in fat tissue in these patients. You can also see other diseases as well as hypertension, patients with increased cholesterol and triglycerides as well. When we look at patients with fasting blood glucose levels, impaired fasting glucose levels, we know, we encourage all patients to go to the physician's office on a regular basis, and these patients should be getting routine blood work. That routine blood work is going to identify patients who have an elevated glucose level for us to keep a watch on to make sure that these patients are being monitored closely because they are at an increased risk for diabetes. So how do we diagnose our patients with diabetes? Our type 1 patients, another blood test that we see is the glycemic. So when we look at our type 2 diabetics and how we treat them, we think first about when we look at our oral anti-diabetic agents. So when we look at our oral anti-diabetic agents, I'm going to refer you to Brunner, page 1505, table 46-5. So looking at medications from a nursing standpoint, we know that any medication we're given, we need to know the action as well as the indication for why this person is receiving this medication. We know that these oral anti-diabetic medications are going to be given to our type 2 diabetics. We can see that there's different classes of these medications, and the different classes is going to sort of differ in the action and the indication for the person receiving the medication. So with these medications, it's not uncommon that we're going to see patients on a couple of these different medications. They are used in combination because of the different action that they do have. Besides just the action and the indication, we also need to know the side effects as well as the nursing implications. And what we mean by nursing as implications is what do I have to check or do to make sure that this medication is safe to give to this patient? So when we look at these medications, all of our oral anti-diabetic medications, two of the big things we see as a side effect is one, hypoglycemia, and the other is concern related to renal impairment. If you look at the majority of these medications, they're excreted through the kidneys, so we need to make sure that renal function is well for these patients to receive these medications. So I think this slide is nice because it sort of puts it all together. So when we look at hypoglycemia, so with hypoglycemia, what we're going to see is patients with severe hypoglycemia. So how are we going to treat these patients? We see that Mr. Smith